Hi everyone, welcome back. Today I'd like to do a brief introduction to cardiac ultrasound. So hopefully you'll get a chance to watch this video before our session this coming Tuesday, but if not, it should be good for you to come back and refer to for review of basic anatomy, the basic ultrasound views that we use, and it should be helpful for your quiz as well as when you actually start using this exam in the future. My name is Sarah Medeiros. I'm one of the attendings here in the emergency room and a former ultrasound fellow here. And I'm also one of the co-directors of Technology Enhanced Active Learning, along with Dr. Michael Schick, who you've already met. And that is my son Wesley down there as an ultrasound model in one of our teaching sessions last year. So I know Dr. Schick has made it sound like maternity leave is some sort of cushy paradise, but I will have you know that it feels a little bit more like this, but I am enjoying my time with my baby, and I look forward to being back in the ER and back teaching you guys soon, so I should be seeing you shortly. Okay, let's get down to business. So first let's talk about the clinical indications, and then we'll talk about probe selection, which probes we use and why, where to place the probe on the patient. We'll discuss 4 standard cardiac views that we use, and then we want to be able to identify cardiac anatomy, just the basics, but we want you to have a good idea of what you're actually looking at. So why do we do this scan, a bedside cardiac ultrasound? When do we do this, and how is it useful? We often do this in trauma situations, so a patient who's been brought in as either penetrating trauma, such as a gunshot wound or a knife wound, or possibly blunt trauma, such as a car accident. We do what's called the FAST scan, and the FAST scan has 4 views. 3 of those are abdominal views, and 1 is a cardiac view using the SubXiphoid window or the Parasternal Long window, and we're generally evaluating for cardiac function as well as any fluid around the heart. Similarly, we'll use this in the rush exam in the shocky patient or hypotensive patient, and it has a similar role there. Really, any patient with unexplained hemodynamic instability, meaning low blood pressure, high heart rate, this is a good scan to do. It can be used to evaluate for pericardial effusion, so any fluid around the heart, and cardiac tamponade, when that fluid is actually compromising cardiac function. Also for unexplained dyspnea, any patient with shortness of breath that you don't have a good explanation for, you'd want to take a look at the heart. And it can give us a good assessment of global cardiac function. Do they have a normal ejection fraction? Is it reduced? Does it look like they have congestive heart failure or cardiomyopathy? And also in the pulseless patient, so these are patients that are coding or brought in under CPR, we can place the probe on their heart and take a look and see if there's any meaningful cardiac activity. So how do we do this scan? So the probe we want to use is called the phased array probe, and or some people call it the cardiac transducer. This is a low frequency probe which allows it to penetrate deeper into the tissues, about 20 or so centimeters, as opposed to a linear probe, which is a higher frequency probe and gives you maybe about 6 to 8 centimeters of depth. But the advantage of the phased array probe is that you can get that depth. You can really see the different structures in the heart, but you do lose a little bit in resolution. We'll talk about the 4 standard views that we use, and let's quickly discuss the dreaded indicator. And I say the dreaded indicator because this is where things can get a little bit confusing. The emergency medicine or the rightward convention is to have the indicator pointed to the patient's right and the screen indicator on the left side of the screen. However, the cardiology convention is the exact opposite. Now, I don't want you to worry about this too much right now, but it's just something that you should know in the future. If you're watching cardiology scans, they might look a little bit different. So let's talk about the cardiac windows that we use. First is the SubXiphoid, the Parasternal Long axis view, and the Parasternal Short, and finally the Apical 4-chamber. So for the SubXiphoid window, you're going to place the probe underneath the xiphoid process, and then you're really going to flatten the probe out and aim it up toward the patient's head or toward their chin. Because you're actually placing the probe on the abdomen, the first structure that the ultrasound waves are going to go through is the liver. And because the liver has a high water content, it's actually really helpful. It transmits the ultrasound waves really efficiently, and it gives us what we call a nice acoustic window for looking at the heart. You should get a 4-chamber view where you can see right and left ventricles, as well as the right and left atriums, and the tricuspid and mitral valves. This is a nice image here, so you can sort of see the slice that you'll be taking on the subxiphoid view to get that 4-chamber view. Okay, so here we have a nice view, a nice subxiphoid view. The liver is closest to the top of the screen, closest to the probe. Next is the right ventricle, which kind of sits right there on the liver. And then you'll see the right atrium, and left ventricles as well. And you can see the mitral and tricuspid valves moving as the heart beats. Here's another example. Again, you can identify the liver, right ventricle, both atriums, left ventricle, and the tricuspid and mitral valves. But you'll notice that this image looks a little bit different. And those red stars, those sort of highlight the outside of the heart wall. And around there you see this fluid pocket. So that's actually a large pericardial effusion around the heart. For the parasternal long axis, you're going to place the probe just to the left of the patient's sternum and aim the indicator toward the left hip. Then you're going to adjust your depth so that the heart is really right in the middle of your ultrasound screen. And this is going to allow for assessment of left ventricular ejection fraction. You're going to be able to see the aortic root as well as the mitral valve and the pericardium, or any pericardial effusions. Here's a nice image there of the long axis view, what we're trying to see. So again here, closest to your probe is going to be the right ventricle, then the left ventricle with the aortic outflow tract, the left atrium. You'll see the mitral valve, and you can see that aortic valve as well in the aortic outflow tract there. Another example here, and again you'll notice that there's a pericardial effusion, some fluid around this heart in the pericardial space. For the parasternal short axis, you're going to place the probe again just to the left of the sternum where you already had it, but you're just going to rotate it 90 degrees from the parasternal long so that now the indicator is toward the patient's right hip. You're going to adjust your depth again, and this time you're going to get a transverse view of the left ventricle. So it's like you're slicing right through that heart. You'll see the mitral valve as well as the aortic valve, and you can assess for wall motion in this view. So here's the short axis view, slice right through that heart. So here you can see the papillary muscles there inside the left ventricle. You can see that nice round donut-shaped left ventricle with good concentric squeeze. And to the top left of your screen, you see the right ventricle as well. This is also from the parasternal short view. For this, you just leave the probe where it is, but you're just going to fan up toward the base of the heart. And in this view, you can see the aortic valve. Here we have the mitral valve view. Again, this is the parasternal short axis, but now you've just angled the probe so that you're right over the mitral valve and you get what we call the fish mouth view. Again, in this image, you can also see a bit of fluid around the ventricle, a small pericardial effusion. And finally, the apical 4-chamber view. You're going to place the probe at the patient's PMI and aim the beam up toward the base. This allows you to assess for relative chamber size as well as looking at the valves. So the right ventricle should be about 2/3 the size of the left ventricle. And you can also look at the valves, and you can place color flow over the valves and look for any regurgitation. This is often best with the patient in a left lateral decubitus position. So if you have the patient roll to their left a little bit, you might get a better view. And here's an example of the slice that we're using to get that apical 4-chamber. Okay, so up toward the top of your screen, closest to the probe, you're going to have the apex of the heart. On the left-hand side is the right ventricle, and on the right-hand side of your screen is the left ventricle. At the bottom of your screen, you can see right atrium and left atrium. You can also see a little bit of that aortic outflow tract there in the middle. Again, another example of an apical view. Here you can actually see the heart bouncing around in there. There's so much fluid around the heart. This is a huge pericardial effusion. And what you have here is called electrical alternans. So as the heart beats, it actually shifts inside the chest cavity, and you can see that on the EKG. Okay, so finally, we're just going to go over some of the anatomy that we'd like you to be able to identify. We've talked about most of these: the right ventricle, right atrium, left ventricle and left atrium, the ventricular septum, the aortic outflow tract, as well as the aortic valve and mitral valve. The papillary muscles, best seen in the short axis view, and the chordae tendineae. Also the pericardium, pericardial space, and the descending aorta, which we didn't mention here, but we'll talk about in our session. So in summary, there are several common indications for bedside cardiac ultrasound that we went over. We'd like to use the phased array probe, which is a low frequency probe to give us good depth of penetration. Also, you're going to use the cardiac mode for the ultrasound, although you can use the abdomen mode if you'd like to see the anatomy a little bit better when we start. We went over the 4 standard views: SubXiphoid, Parasternal Long, Parasternal Short, and Apical forechamber. And we identified some important anatomical structures that we will look for again during our scanning session. So hope this helped you guys, and if you have any questions, feel free to contact us. Dr. Schick will likely also be uploading a cardiac video with a little bit more detail, so please take a look at that as well. All right, we'll see you in class.